What is Allan-Herndon-Dudley syndrome? This syndrome is also known as MCT8 deficiency or SLC16A2 mutation. So where does it come from? And how does it affect people? Here we will answer some of those questions. We will learn about basics of frequency and inheritance patterns, the causes of the syndrome, clinical manifestations and symptoms, diagnostic testing and prognosis, and possible treatments. The study of genetics is very complex, but here is a quick review of the principal parts that help us understand this syndrome. Inside human DNA we have 23 pairs of chromosomes. 22 pairs determine how the body works overall. The 23rd pair mainly deals with the sexual characteristics of the person. We know that males have an X and Y pair, and females have an X and X pair. Every new baby at the time of conception receives an X chromosome for mom, along with the other 11 regular chromosomes, and an X or Y chromosome from dad, along with the other 11 regular chromosomes, which adds up to 23 pairs when put together. This determines ultimately whether the baby is a male or female genetically speaking. Women have 2 copies of the same type of chromosome, aka X chromosome, with the same kind of information in both, as you can see in the location of the gene. On the other hand, in men the X and the Y chromosomes do not carry the same kind of information. The X is significantly larger than the Y chromosome. The code in the Y chromosome almost entirely produces sexual characteristics specific to males only. Solely the tips of the X and Y chromosomes have similar kinds of genes. The information code that is needed for the building of the transporter site, aka door, which allows the crossing of thyroid hormone into the brain, is found in the leg of the X chromosome where the MCT8 gene is located. The thyroid hormone transporter site code SLC16A2 gene. There is no counterpart of this gene in the bottom of the Y chromosome. Because females have 2 copies of the MCT8 gene, females can carry the defect in one of their X chromosomes and still develop normally, since the non-defective X chromosome takes over the functions. Because the backup information is missing in the Y chromosome, then the copy of the X chromosome available in men would have to function perfectly to avoid conditions such as Allan-Herndon-Dudley syndrome. This is it. No backup. So there is a 50% chance that a male child will be affected due to a defective genetic code. Approximately 1 in 1 million children will inherit the defective gene or mutate spontaneously during conception. The barrier that is found between the brain and the rest of the body controls tightly what crosses into and out of the brain. If the code to build these doors embedded in the barrier is defective, then the doors can either randomly malfunction or stay completely closed depending on the severity of the defect. This means that this thyroid hormone cannot cross into and out of the brain space properly. Inside the brain we find millions upon millions of these tiny specialized cells called neurons that make it possible for a person to function by conducting electrical impulses. This activates the different functions within the brain and the body. Each one of these neurons has an axon, also known as cable, coming out of the central part of the cell that contains the brains of the cell. Each cable has a wire that is insulated with a covering called myelin sheath. Myelin sheath, aka the insulation around the wire, does not get formed properly without the availability of the thyroid hormone. Thyroid hormone is produced by the thyroid gland located on the trachea. Therefore, electrical signals do not travel at the appropriate rate to stimulate the functions in other parts of the body. To put it in perspective, if electrical signals traveled in miles per hour, and the normal speed would be 200 miles an hour in the affected neurons, it would slow down to 150 miles per hour instead. The thyroid hormone, which is not only essential for the conduction of electrical signals, is also very important for the regulation of all these systems and bodily functions such as the heart, the digestive system, the skeletal system, the urinary system, the reproductive system, eyesight, liver functions, pancreatic functions, appetite, and weight gain. very early in human development in the first trimester of pregnancy, which occurs around the time a woman tests positive for pregnancy. As the neurological system begins developing, thyroid hormone becomes essential for neurons to start creating and maturing the cable cover aka myelin sheath, needed for electrical signals between the neurons to travel at the proper rate. The most recent research reasoned that if development in utero is not aided by early treatment with thyroid hormone analogs, which can cross the barrier without passing through the doors, the baby that is born will look apparently normal at birth on the outside, but he will not be so on the inside. Later on, he will not be able to meet the milestones and become disabled, partially or completely depending on the severity of the defect in the code. Early signs that something is not right include babies with low or mixed muscle tone, especially on the neck and trunk, and inability to lift up their head several months after birth. Also irritability and lack of self-soothing skills. Inability to hold objects in hands for extended periods of time, especially food or bottles, causing poor feeding. Also, weakness in suckling and swallowing contributes to low weight gain. Inability to get into an unsupported sitting position and eventually pulling into a high crawl position for independent movement. Not only does the imbalance in hormone levels cause children to become disabled, but it will also contribute to health problems throughout the rest of their life. If the thyroid hormone level in the brain is low, and the thyroid hormone level in the rest of the body is high, the chemistry in the entire body fluctuates out of range. This might mean children will spend many days in the hospital and being managed by medications and therapies to keep them stable and prevent premature death. Diagnostic testing includes looking for the physical manifestations known to be present in Allan-Herndon-Dudley syndrome. Also blood testing to look primarily for the low levels of reverse T3, the elevations in free T3, a decrease in free T4 levels, and a slightly elevated TSH level, and genetic testing for the presence of the mutation in the SLC16A2 gene, which is the MCT8 gene. Among the typical interventions used with people diagnosed with Allan-Herndon-Dudley syndrome are medications for seizures and spasms, medications for digestive issues, surgical insertion of feeding tubes, and physical, occupational, and speech therapy. The prognosis. What is their life expectancy? The quality of life is severely compromised as far as ADLs are concerned due to the development of muscle contractures and an inability to sit, stand, and walk independently. Peripheral dysthyroidism will present, possibly expressed as cold intolerance, sweating, intestinal function disorders, tachycardia, high blood pressure, and sleep disorders throughout their entire life. Affected individuals may live up to 60 years old, but many will have a shortened lifespan due to malnutrition and recurring infections. There are possible treatments currently undergoing investigation. The current medication research. The DITPA analog preborn administration trial. The post-birth TRAC administration analog trial. Administering a combination of PTU and T4, which are readily available and approved for treatment. The comparisons between DITPA triac and phenylbutyrate. The treatment with levodopa/carbidopa, which is in the preliminary stage of treatment. In the future, starting to trial sobeterome analog administration. And also in the future trialing genetic therapy. We hope in the near future a cure is found for Allan-Herndon-Dudley syndrome, and all affected individuals can one day enjoy life like every other child. Please refer to the comment section for more information. Thank you for watching.